has an extensive CV, but I'll just mention a couple of things. She has a PhD in epidemiology from the University of California, as well as a master's degree in nutrition and public health. As well, she's a registered dietitian. Do you want to go over the Molina stuff or disclosures? Do you have any disclosures?
Oh yeah.
I don't have any disclosures.
Advance the next slide. Yeah, we don't have anything to disclose.
No.
And next slide.
More slide.
And we have partnered with Molina Healthcare. If you have a Molina patient who you'd like to consult with us on during our P&T session, which you're at right now, or ComTC, or our asthma pulmonary telehealth clinic, you may do so. There's some information here. Contact Clancy Tarbox, our coordinator for telehealth, for more information on this. You can be reimbursed $150 per consultation, and it's not limited to just one per patient. So it's a really good deal, and you can get paid for it. So please bring your patients.
Okay, good morning everyone. Envision had asked me to talk about a global epidemiology topic related to pediatrics. And so I kind of racked my brain and tried to come up with things that I've been hearing a lot about lately. So hopefully they'll be of interest to you. So as we kind of head into the presentation here, I'd like you to think about, maybe write down what comes to mind. If you've heard of epigenetics, or the developmental origins of health and disease hypothesis, if you've heard about the microbiome, and then if you've heard about a connection between those two things, the microbiome and epigenetics, and then child and adult health, and if you're considering any of those concepts in your current practice. So I'll give you a minute or so to think about those questions and write down what comes to mind. So please feel free to stop me if you have any questions as we're going along.
Yeah, Dr. Yates, I'm sorry to interrupt. One thing we forgot to do is so two hours out there on the phone. As a reminder, if you want to receive your CME or certificate of participation, you have to announce your name.
So we already got Nina, right?
That's right, we did get Nina Dougherty. And who else do we have?
Cassandra Vanderpool.
Okay.
Welcome, Cassandra.
Thank you.
Are you down in Las Cruces still, Cassandra?
No, I moved to Albuquerque in July.
Oh, okay.
Sorry for the interruption.
Oh, no worries. So traditionally in epidemiology, we've studied a lot of risk factors for poor health and kind of come up with the fact that, there's disparities demographically across age groups, for example, and across socioeconomic status. There's geographic disparities, so people in one part of the world aren't suffering from the same thing as people in other parts of the world. There's behavioral disparities based on, for example, people who exercise every day versus people who don't exercise every day. And then biochemical risk factors, for example, like high cholesterol. But one of the things that often comes up is that sometimes we have people with the same behavioral risk factors, for example, or the same environmental risk factors, and they end up with different outcomes. And that always kind of stopped us in our tracks, and we were wondering, well, what's going on? And then genetics came up, over the last probably 20 or 30 years, and we thought maybe genetics was the answer to why two people with the same risk factors would end up with different outcomes. But lately, it's been seeming like it's even more complicated than that, and that epigenetics and the microbiome, the two things that I'm going to talk about today, might be responsible for some of this disparity and kind of observed outcomes for people with the same risk factors. So I'm going to start off talking about epigenetics and just first off define it for you in case you're not familiar with the term. So it's the study of heritable changes in gene expression that don't involve alterations in the DNA sequence. So we're not changing the underlying DNA sequence, we're just changing how it's expressed. And that happens in a variety of different ways. I've listed some of them there. I'm not going to go in depth into kind of those terms because it's a pretty biochemical scenario, but if you're interested, you might want to look up a little bit more on DNA methylation, histone modifications, and non-coding RNAs, which are kind of the three main ways they've found that this process happens. And all of this kind of originated, if you've heard of the Barker hypothesis, that was kind of the original epidemiologic hypothesis that arose because Barker found that infants that were small with a large placenta had the highest blood pressure as adults in a study that he did in the UK. And so he postulated that, something had happened during the fetal period that set that infant up to have health problems later on in life. And originally people kind of, they were a little bit skeptical because they said, well, there's lots of things that happen in between the fetal period and, 40 or 50 years later. But I would say that the evidence has really been, becoming stronger and stronger for this particular idea. And it's now called the developmental origins of health and disease hypothesis. And there's two aspects to it. And as I'm going through this presentation today, I'm going to be talking to you about both undernutrition and overnutrition. Undernutrition is what I do when I work outside the US because it's still quite a problem in some areas of the world. And then overnutrition, of course, is what you're probably dealing with more often on a daily basis. So they've shown that both when a mother has protein, nutrient, and energy restriction during her pregnancy, and when she has excess energy and excess fat intake, and this includes obesity, for example, and gestational diabetes during pregnancy, it can have long-term impact on the fetus. The most famous study on undernutrition has to do with the Dutch famine birth cohort, which occurred during World War II. There was a well-defined famine in the Netherlands, and they had very good medical records for those individuals and could follow them for quite some time. And they actually had records about whether they were exposed to the famine in early gestation, middle gestation, or kind of at any stage of gestation, and have published, this is kind of a summary for you of, they've published lots and lots of different papers from this cohort looking at outcomes that are tied to famine exposure at those different stages of gestation. So famine exposure in early gestation, they saw an increased risk of adult obesity, potentially with stronger or more pronounced effects in women, high cholesterol and triglycerides, disturbed blood coagulation, hypertension, and coronary heart disease, so some metabolic disturbances. They also saw some mental illness increasing with schizophrenia and antisocial personality disorder increasing. And an interesting finding was that birth weight was not necessarily altered in those infants, so there wasn't necessarily an outward manifestation of the trauma that had happened that had changed kind of things that were going on in their bodies. If they were exposed to famine in mid-gestation, there was an increase in microalbuminuria, decreased creatinine clearance, and then increased incidence of obstructive airway disease, so probably some effects on the kidneys and the lungs at that point during gestation. And then if they were exposed to famine during any stage of gestation, they saw elevated glucose levels in adulthood, perhaps pointing to some kind of insulin secretion defect. So across all of the infants that were exposed seemed to have some sort of long-term effects from being exposed to undernutrition in the womb. Lately, of course, we've been a lot more interested in overnutrition as well, because we have a lot of women in the US that are heading into pregnancy obese, and we have, depending on the population that you're looking at, about an 8 to 14% incidence of gestational diabetes. It's the most common complication of pregnancy. And so what they think happens here, I thought this was a really nice illustration for you, is that there's maternal obesity or either type 2 diabetes or gestational diabetes, which leads to the mother having hyperglycemia or hyperinsulinemia, which in turn leads to the fetus having hyperglycemia, hyperinsulinemia. And that has several consequences, including adipocyte cell dysfunction, pancreatic vascularization deficits and damage, and then hypothalamic changes, which has long-term effects on the offspring in terms of the pancreas, obesity, metabolic disturbances, endothelial dysfunction, hypertension, which consequently leads to increased risk of cardiovascular disease and diabetes. This is one of the more interesting studies that's been done looking at exposure to diabetes during pregnancy. It's an interesting design because they tried to find families who had one sibling that was born before a mom was diagnosed with type 2 diabetes and another sibling that was born after the mom was diagnosed with type 2 diabetes. And they found 19 families that had at least one one offspring that had diabetes, and found that the odds ratio for diabetes in siblings born after the mother's diabetes diagnosis was 3.7, so about 3.7 times the odds of having diabetes if you were born after your mother had a diabetes diagnosis, meaning that she had diabetes going on during her pregnancy with you. They also looked at siblings who didn't have diabetes and found that their mean BMI was about 2.6 kilograms per meter squared higher if they were the offspring of a pregnancy in which diabetes was present versus not present. And they didn't see the same effects for a diabetes diagnosis in the father. So it seemed to be linked to the exposure, the maternal exposure. And the nice thing about using siblings is you control a little bit for genetic factors and environmental factors that might explain other reasons why you might expect that people in the same household would end up with diabetes. Next, I want to talk to you a little bit about the microbiome. And again, I'm going to define this so you kind of know what it is if you're not familiar with the term. And basically, we have all sorts of microbes that live on us in our nasal passages, our oral cavities, our skin, our gastrointestinal tract, and our urogenital tract. And I'm going to focus primarily on the gastrointestinal tract, so they call that specifically the gut microbiome. And it's been emerging lately that this gut microbiome is really essential to healthy postnatal growth and development. And I want to talk to you about this fascinating study that just came out in Science. Kwashiorkor is a form of severe acute malnutrition that we encounter among young children outside the U.S. It's not very common in the U.S. unless there's situations of abuse or neglect, but characterized by edema, failure to thrive, hepatic steatosis, skin rashes and ulcerations, and anorexia, loss of appetite. And, we used to think it's traditionally been called protein energy malnutrition, so people thought it was caused by, inadequate protein intake, which is probably related. But, I remember I was working in Bangladesh for a while, and people were saying, well, why does this kid end up with Kwashiorkor and this kid doesn't, even though they're in the same exact environment? and having the same exact exposure to poor diet or infectious disease. And so a recent hypothesis that they've come up with is that some sort of disturbance in the microbiome, in the assembly of it, the function of it, for example, via even infection with a pathogen, actually affects risk for Kwashiorkor. So this is another fascinating study where they actually use twin pairs. They followed them for their first 3 years of life, and 50% of the twins, both of them remained well-nourished. 43% of them, they became discordant. So one twin became malnourished while the other stayed well-nourished, and 7% both became malnourished. So those discordant twins were really of interest to people because they said, okay, they probably have similar genetics, similar environment. What is going on that causes one of them to end up with severe acute malnutrition and the other to not suffer? And so what they found, that they kind of looked between the twins that had stayed healthy and the twins that had either a healthy twin that had a healthy twin and a twin with severe acute malnutrition. And they found that the healthy children had what we might call more mature microbiomes. We know that the microbes that are in the gut are kind of in flux for the first 2 years of life, and especially for the first 6 months of life. And by age 2, the microbiome starts to settle down. So the healthier children had a microbiome that was closer to kind of what you would expect for their age group and for their microbiome to be heading towards where it needed to be. Among the discordant pairs, they treated both twins with a peanut-based, ready-to-use therapeutic food, hereafter abbreviated as RUTF, and that's composed of peanuts, vegetable oil, milk, sugar, vitamins, and minerals. You may have heard it called plumpy nut. It's been in some news broadcasts. They've been using it extensively to treat severe acute malnutrition. And the fascinating part of this is when they gave the children who had, the immature metabolic function, this RUTF, their gut microbiome advanced, it matured. But when they stopped it, it regressed and went back. So this shows you kind of an interaction between a dietary food and the gut microbiome in a way to potentially manipulate it, but a non-sustainable way because once the food was taken away, they regressed. They also did a really interesting follow-up study in mice where they took what are called germ-free mice, so basically mice that don't have a microbiome, and they transplanted fecal communities from 3 discordant pairs into those mice, and basically found that with the Malawian diet, which tends to be inadequate in protein and multiple micronutrients, and the mouse having what's called a Kwashiorkor microbiome, so a microbiome, a fecal community from a child that developed Kwashiorkor, the mice actually developed weight loss and abnormal amino acid, carbohydrate, and intermediary metabolism that was also transiently ameliorated with the RUTF. So they were able to recreate the effect in a totally different organism by transplanting the microbiome, which I think is fascinating. And so their conclusion was actually that the gut microbiome is potentially a causal factor in Kwashiorkor. So that's the story on undernutrition. Now I want to talk about the gut microbiome and obesity, again, because I know that's probably more related to what you're doing on a daily basis. They've done, again, a number of animal studies that have shown that transplanting these mice without a microbiome with the microbial community from an obese mice actually leads to increased percent body fat versus if they get a microbiome from lean mice. They've also shown, very interestingly, that transplanting these microbiome-free mice with microbiome from mice who are fed a typical Western diet also led to increased percent body fat versus giving them the microbiome from mice who were fed a low-fat, plant-based diet. And the really interesting thing is that they found that this percent body fat was not being mediated via increased calorie consumption, food consumption, because they can control that pretty well in mice. And we're postulating instead that it's due to increased efficiency of calorie transfer and the actual effects on the host metabolism of calories that are being facilitated by these different types of microbiomes that evolve from the different diets. I wanted to show you this study on antibiotic exposures because this is another way that the microbiome is affected. We know that antibiotics can change the composition of the microbiome by killing off certain types of bacteria and also the quantity of bacteria that are present. And I was talking to some of our students about these studies that were coming out showing that antibiotic exposure could potentially predispose children to obesity, and they were like, well, what is the connection there? And the connection is the change in the microbiome. So this is a study that was done with a longitudinal birth cohort in the UK of about 11,500 children. And they looked at their exposure to antibiotics during 3 different time periods, less than 6 months, 6 to 14 months, and 15 to 23 months, and then examined their BMI Z-scores at 6 weeks, 10 months, 20 months, 38 months, and 7 years. And they had lots of data on social and behavioral risk factors for obesity, so they were able to control for those factors. And they found a relationship with exposure to antibiotics during the first 6 months of life. And that it was kind of associated with consistent, modest increases in body mass from 10 to 38 months. They didn't see an effect at 7 years, but there's another study that did find an effect at 7 years, so it's a little bit unclear if this is persisting into later life, but it does seem to have an effect from that 10 to 38 month period. Next, I want to talk to you about kind of the interaction between the microbiome and epigenetics, and this I have really only been seeing over the past few months, so hot off the presses. And one of the questions that has come up is how plastic is the epigenome during the postnatal period? So, we talked about that developmental origins of disease hypothesis where we have the mother going into pregnancy obese or having excessive gestational weight gain or developing gestational diabetes. Is there anything that can be done after the infant is born to kind of reverse some of those effects? And there is some indication that there likely is. You've probably seen a number of epidemiologic studies that have linked breastfeeding to children being leaner. There's studies that find that there is an effect, there are studies that find that there isn't an effect, but this has been proposed as a potential mechanism for the reason why breastfeeding might promote leaner kids. And it's postulated that the breastfeeding actually is going to affect the gut microbiome in a different way than formula feeding. And by creating a different type of microbiome, those bacteria are actually going to produce different types of compounds that are going to have effects on the epigenome, which is kind of a fascinating connection between those two things. So in this paper, they were saying that they think breastfeeding leads to more bacteria that produce folate, which leads to more DNA methylation, which is one of those factors that we mentioned could be involved in regulating the epigenome. And then that formula feeding would have a different effect, leading to more bacteria that produce butyrate, a short-chain fatty acid, which actually causes histone modification, so a different type of regulation of the epigenome. And so they were saying that they think that these, different metabolites, the folate versus the butyrate, were leading to altered gene expression in intestinal cells, hepatocytes, adipocytes, and consequent altered energy balance in kids later on in life. So kind of a biological hypothesis for the effects of breastfeeding on weaning kids. This is kind of an illustration for you of what I was just talking about. I know some people really like visuals. I like this visual to help me understand what they were proposing. I wanted to highlight this study for you because it relates to this idea of being able to do something after a pregnancy where gestational diabetes has occurred to mediate some of the metabolic effects on the infant. This was a study that was done in Colorado, and it was a retrospective cohort study, so they had 94 offspring of a diabetic pregnancy and about 400 offspring of a non-diabetic pregnancy. And they looked at the relationship between reported breastfeeding status. So they asked the mother about what she did during the pregnancy in terms of breastfeeding, and came up with this concept of breastfeeding months because most of the mothers did not breastfeed exclusively, so they kind of waited months where they had also given formula and added it in there and used 6 months as the cutoff because that's the current recommendation for breastfeeding, minimum recommendation. And then they looked at the growth trajectories of the children during infancy and also during childhood, and found that children of the offspring of diabetic pregnancies who had greater than or equal to 6 months of breastfeeding had a slower BMI growth trajectory during childhood and slower kind of period-specific growth velocity between 4 to 6 years of age and 6 to 9 years of age compared with children from diabetic pregnancies that had less than 6 months of breastfeeding, and similar beneficial patterns in the offspring from non-diabetic pregnancies. So it seemed like breastfeeding had a mediating effect on some of the metabolic changes that were the result of being exposed to diabetes in utero. So another fascinating study, I think. I think there's lots of implications for practice of this information, and I'm hoping we can discuss more during the discussion section. In terms of the epigenetics, preconception and interconception care have been really hot topics lately, along with, of course, prenatal care during pregnancy, which there's some access issues in New Mexico. But the CDC just launched a big campaign called Show Your Love, trying to bring preconception health to the forefront, because we'd like it if women were actually heading into pregnancy at a healthy weight, heading into a pregnancy with their chronic conditions well managed. And hopefully with the Affordable Care Act and some of the shifts that are occurring around that, preventive care will come to the forefront. We also want to think about the exposure of pregnant women and their offspring to nutrients that affect the epigenome, like folic acid. Lots of things that can potentially affect the microbiome. They found that children that are the result of a C-section versus a vaginal birth have a whole different microbiome kind of from the start, because the vaginal birth is kind of where the infant is first colonized. Usually the fetus is coming out kind of without really having an established microbiome. The early age feeding patterns, I mentioned breastfeeding specifically, and there are components in breast milk called oligosaccharides that seem to have specific effects on the microbiome, along with other aspects of breast milk. This whole excessive hygiene thing that we have going on right now in the US is probably affecting our microbiome. Use of antibiotics when antibiotics are not needed, as mentioned earlier, can have an effect on the microbiome. And then there's been a lot of interest lately in what are called prebiotics, which stimulate the growth of certain types of microbes in the gut, and probiotics, which are actually sending live bacteria into the gut. And they've actually found that some probiotics are actually obesogenic. They've actually been used in the past in animals to promote growth, along with antibiotics, I'll mention. It's been used in farming for a long time to fatten animals up. And so we need to be paying attention to what types of probiotics people are consuming. You may have heard about the whole idea of fecal transplantation, which they've done with some obese adults and have seen some effects. And then I think a real question for me is kind of, is the postnatal kind of infancy period the only time where the microbiome can be manipulated, or can we, do long-term dietary change, for example, switching to the more low-fat plant-based diet that was mentioned in some of those mice studies, and will that have an effect on the microbiome for adults? So I'm hoping that some of this information was new to you, so it would be great if you can write down some of what you learned from the presentation. If you have any questions, I'd love to have a discussion with you. And then I'd love to hear how you think that you could apply this information that I mentioned today on epigenetics and the microbiome to your practice that you're doing out in the community.
Shall we take roll call again before we start the discussion? You think?
Sure. Let's see. So at this point we have Nina Dougherty and Cassandra Vanderpool. Has anyone else joined us on audio?
Yes, Erica Smith at Hopi.
Welcome, Erica.
Thank you.
Anybody else on the line? So does anyone have questions about the presentation for Dr. Yakes? I have some, but I want other people. Start.
Was somebody going to start?
No, go ahead.
This is Cassandra. I had a question, Beth, about specific bacteria, because you've been talking about the microbiome, and I assume that they're starting to do studies on the effects that specific bacteria have in regard to these things. Do you know if they have, and if there might possibly be some kind of chart that summarizes what they've found about specific bacteria so far?
So I haven't found a nice chart that summarizes everything, but there is information that's sprinkled throughout all of the articles that are in the references. And I'm happy to pick out, I think there were one or two that really discussed it extensively, and I don't remember all the names of the bacteria off the top of my head, but I'd be happy to send those to you, Cassandra, because I think I have your email, or I could send it to the whole list of
Envision, yeah, and then
Yeah.
we can post it.
Sure.
That would be good.
Yeah, I'd be happy to do that.
Yeah.
It's a good question.
There is a lot of, you hear the two main one is lactobacilli, like acidophilus, and the bifidobacteria, right?
Mm-hmm.
Do you hear the most about those?
Well, and I'll go back to this slide, these firmicutes, and I hope I'm pronouncing that correctly because I've only ever read it. I haven't heard it pronounced.
Yeah, me either.
But they seem to believe that those are kind of more obesity promoting
Okay.
versus the bifidobacteria, which are kind of promoting lean kids. And again, the connection to the infant formula versus the breast milk.
That's
Yeah.
interesting because I was wondering, and so on your slide about gut microbiome and obesity, so it's back like 4 slides from where you are now. They did the study with the microbiota that was developed right from the low-fat plant-based diet and the improved efficiency of calorie transfer. So basically, it improved them utilize their food better? Is that what they're saying?
Well, in terms of how, some of those microbiota are actually increasing obesity.
Okay.
If that makes sense.
Okay.
Basically,
That does make sense.
using the food even more efficiently than we would use it on our own.
I see.
And efficiency meaning extracting
Right.
more calories
Right.
from it. if that
Because they're
makes sense.
metabolizing more.
Yeah.
And you hear that about fiber, right? They're able to metabolize fiber, and then we absorb some of the long chain, or the fatty acids or whatever they make from that. Okay. So that makes sense. And then the following study, it shows how they had a higher BMI, younger.
Beth, in any of those studies on the obese mothers, did they look for a difference between obese mothers who are metabolically normal versus those who do have the hyperglycemia or hyperinsulinemia? Because about a third of obese people are metabolically normal, and I'm wondering if it is the weight status or the hyperglycemia, hyperinsulinemia that's more responsible.
Well, I think the hyperinsulinemia and the hyperglycemia are definitely having a clear set of effects. With obesity, again, that's a really good question, and I would particularly wonder about these mothers that had one child, before they were diagnosed with type 2 diabetes, and then another child after. I can look back at that article and see if they had recorded BMI. And if there would be exposure to obesity in both of those pregnancies, and then the exposure to the type 2 diabetes is a different exposure. I haven't seen any studies that have looked specifically at that, but again, I'll write it down and I'll look and see if I can send a follow-up on that, because I think it's a really good question. And I feel like articles are coming out on this every day.
Yeah.
So if somebody hasn't done it already, maybe
know.
someone's thought of it, and they're going to publish it soon. So I'll write that down.
I wondered that about the
Well,
Dutch famine study, too. If they had BMI data for that, that would be interesting.
I would suspect that most of the individuals were
Normal.
there wasn't obesity.
Yeah.
Yeah.
When I just saw within the last month, a study that came out on fecal transplantation in relation to ulcerative colitis, and they found that when they, did you see that? This is such an interesting topic, I think, and it's really amazing the research that's being done in this area.
And that was actually in kids, and they found that most of the kids actually tolerated it pretty well, and some of them had an effect from the fecal transplantation. I think it's kind of an uncomfortable idea for a lot of people.
I know.
But
I thought that's
if it's
gross, but I think if
effective,
it works.
yeah.
For inpatient, we've been doing that for quite some time. It literally saves people's lives in the ICU. And it's hard to, I just went to a talk about this at the dialysis conference at the beginning of the year, and there's a critical care doc who does fecal transplants with a lot of his patients. Not only do they put yogurt down their NG tubes for almost anyone that they could NG tube feed in the ICU for the microbiota health, they do fecal transplants, and it is a complete metabolic change from the moment they do it to within an hour of how much these people improve. And they've been doing it for quite some time, but he was talking about how there's easily 400 maybe plus different species, and that's why the fecal transplant is so much more beneficial than a probiotic even in yogurt, because it's not just the quantity, it's all of the variation.
Well, and it seems like with yogurt, for example, they haven't really done a lot of research as to, and that relates exactly to, I think it was Cassandra's question on what bacteria we should be trying to promote. Like I said, some of them have actually been shown to be obesogenic.
Right.
So I think we need to pay more attention to what we're doing in terms of that.
Yeah, and now probiotic supplements are super hot. Everyone wants to buy them. And so, the benefit of having someone eat yogurt is that it's a regulated item, and they can only use certain things, and they actually have good quantity, as opposed to something you're going to buy on the shelf in a supplement store that's not regulated at all. You don't know what's in it. You don't know if it's even good quality, if it's still live bacteria.
Yeah.
But yeah, the guy there, he's at Oregon State University Health Sciences. He's published quite a bit of research. He has a PhD in nutrition, and he's a doctor. For at least 2 decades, he's been doing research with probiotics and yogurt and all this stuff. And he's one of the few people in this country that really do research, but it's only in his ICU, so very limited numbers
Yeah.
of people.
And getting it out into the community, I think, is important.
Yeah, I had a question. Cassandra, did you have more questions? Am I talking over you?
No, you're fine. Go ahead.
Okay, I was wondering, so that Dutch famine study is really interesting. So you were saying probably there was no obesity, and they probably went in with normal weight. But what I was wondering is, like, pre-gestation weight loss good enough, you know what I mean, to create a healthy environment? Say I went from being obese to a healthy weight, and then I got pregnant. Has anyone studied that, you know?
Another really interesting question. I don't think that would have been a situation that could have been studied through that Dutch famine.
Yeah, I know.
Study.
I was wondering if
There's actually a number of famine studies out there. There's one from Nigeria. There's one from China. But in most cases, from earlier in the decade, when obesity wasn't nearly as prevalent as it is now. I think it would be a fascinating study to do. Yeah. Actually. I think that we are, in general, not very successful in helping people to lose weight.
Right.
So, it would be a hard study to do, but I think it would really be worthwhile to see kind of what the effects of that type of intensive intervention would be. The other problem is that people are just not necessarily planning their pregnancies. So you'd have to find a group of women that was really planning their pregnancies, motivated, and
fertility clinics.
Yeah,
you might be able to, but then some of them might have PCOS.
And, we looked last year in the maternal and child class about preconception counseling and fertility clinics, and most of them were still not covering some of the stuff about getting people into optimal health prior to pregnancy, because of course obesity affects fertility, so obesity is actually probably more prevalent in the fertility clinic population than the general population. So having an intensive lifestyle intervention would probably be quite beneficial.
Yeah, that would be interesting stuff.
Hard and intense, and our medical system isn't really set up for that right now.
Right.
So
that was interesting. I had another question. Let me find it. The plumpy nut, which I find really interesting. So there's such a combination of nutrients. There's essential fatty acids, there's all these different vitamin D, sugar, vitamins, minerals. Did they say anything about, if they thought the effect of the improvement was that they're feeding these fats and that's helping control the inflammatory environment, or is it that it's feeding the bacteria and it's promoting a more healthy bacterial environment?
Yeah, I think, one of the issues that's come up over the years is, going around and giving kids one supplement at a time is kind of silly when the diet is inadequate in a lot of different things. And so pumping nut was kind of developed as the solution to that, to deliver healthy fats, healthy protein, and then also the vitamins and minerals. So it's really impossible to pinpoint what exactly caused the change in the microbiome, other than the fact that they went from a likely protein inadequate, vitamin and mineral inadequate diet to a diet that was having those things in it. But they wouldn't, from that study, be able to pinpoint exactly what aspect of the pumping nut caused that effect.
I was wondering that because that doctor that does the research, he was saying that when they do fecal transplants, within an hour they test all these metabolic factors and the inflammatory cytokines are like in half. And it was just from changing the microbiome because they're secreting all these endotoxins and they're creating that environment, and then just transplanting it brings it down. So I wonder, when you're starving, your bacteria is going to be moving and the more opportunistic bad guys are going to be multiplying and taking over. So does just feeding reverse that, or something? That's really interesting.
Yeah, and inflammation certainly, in obesity as well, is going on. So that's fascinating.
It's really interesting that I've been reading all these different books about probiotics and microbiome and psychiatric disorders like schizophrenia and autism. So they think that the mom, when you even have a vaginal birth, you're kind of giving them all your microbiota. And if it's a certain kind of disbalanced microbiota, that it might encourage or promote these kind of things. And it's because of the endotoxins and the nutrients. And then if you start feeding the gut and making it a healthy gut, that sometimes these children or these schizophrenic people improve. Like you've probably heard of the GAPS, the gut and psychology syndrome, different kind of research that and some of it's kind of iffy. I have to read to it more, but it's really, really interesting.
Yeah, I think it's fascinating. I mean, we always want to separate. Somehow we want to separate out the gut from everything else, but it's interacting.
It's so related,
with the
right?
whole body.
Mm.
So I would definitely be interested in learning more about that.
Yeah, I'm gonna have to read a lot of these studies.
So Beth, I'm just wondering, have you seen any research on the microbiome and celiac disease? Like, I'm wondering if some people who have problems with their gut because of gluten intolerance, if there's been any fecal transplantation done there and what effects it has. Have you seen anything?
I know, I haven't. I had seen the one that you had mentioned on ulcerative colitis, but I haven't seen anything. I didn't really look for specific clinical conditions because I wanted to keep this presentation a little bit more general. But again, follow-up that I can certainly do and see what's currently out there in terms of celiac. I think it would be interesting, certainly, to look at that.
There's a
Or
lot.
I can look too. You don't have to do my research for me. I just was wondering
you know
if
what,
you happen to have seen
Cassandra?
it.
There's stuff you could find out. There's this hypothesis that what creates things like Crohn's disease, ulcerative colitis, and celiac is the fact that maybe even for decades you have this altered microbiome, and because all these endotoxins are being released and damaging your enterocytes, it makes you susceptible to something you might not develop if you had a healthy microbiome. And I've been reading a lot about it, and there are tons of different research articles published, but the quality of them I couldn't speak to because I haven't sat down and done some sort of systematic literature review.
Yeah,
but you can find stuff.
That's what I've been wanting to do too.
It's
but
fascinating.
It's hard to find the time, and there's just so much that's coming out recently. And I don't mind looking all this stuff up because I use it when I teach.
Right.
And I use it when so I'm happy to follow up on all this. And I think
It's such a big thing right now. So many people are being diagnosed with gluten intolerance.
Right, and part of it is that, and it's funny because the more I read about these gut things, a lot of it is that we have this really highly processed, sugary diet that really encourages these bacteria that are going to be, secreting a lot of endotoxins and damaging your enterocytes. That kind of promotes the growth of them. So it is really, really interesting.
Yeah. And that it relates to the last kind of big question that I had is kind of the long-term effects of diet and can we only intervene with 6-month-olds or can we, throughout the life course, throughout the lifespan, really be promoting a healthy diet that can get people's gut healthy?
Right.
Because, you're saying it's just years of exposure to these endotoxins.
Yeah.
So at what point do we have to intervene?
Right.
To get people to have a healthy gut to not have those consequences.
Have you heard of what's his name? Dr. something Valentine Haas, who was, when was he? I want to say it was the early 1900s. Before they knew what celiac was, he cured celiac patients. He kind of came up with this definition of celiac. And at that time, it included Crohn's, ulcerative, all these other things. And he would treat people with a diet he developed called the specific carbohydrate diet. Have you heard of this?
Mm-mm.
So it's no starches. The only sugar you're allowed is small amounts of honey because it's mostly fructose and you absorb it earlier in the gut. So basically what you do is you have certain carbohydrates that are going to help starve the bacteria but feed your body. And a lot of what he used to use was really ripe bananas. So I think during one of the world wars, there was a loss of bananas, and he even published something in the New York Times or some local paper about, if you're a celiac patient, we're going to get you bananas. It's really interesting, but his last name is Hass, Hass, and the diet he created is called the specific carbohydrate diet. Nowadays, people use it to treat, it's starting to get really popular with autistic parents using it, so there's a lot of kind of iffy books about it, but then there's other people that use it to treat small intestinal bacterial overgrowth and different things like that. So you can look into that, Cassandra, and a lot of the different books have pretty good research reference sections if you want to. It's been researched for a long time, but of course no one wants to listen to something as simple as feeding your health and changing your mental health or something. But there's quite a bit of research, and it's been going on for decades. It's just becoming popular and in the media now, and so everyone's really interested, which is probably good for us in research.
Yeah, and I think, you know, this whole idea of connecting it to the Kwashiorkor, for example,
Right. That is
a
interesting.
new idea. I mean, that got published in Science, so that hasn't been really put out there in
Yeah.
a way that was well supported in the past. And I think the connection with obesity as well. Like I said, they've known for lots of years that antibiotic use in animals and probiotic use in animals can
Right.
essentially promote fattening of
Right.
animals. So I'm not sure why we're so surprised that it could have the same effect in humans.
People, right.
But,
Yeah.
you know, it just hadn't really been emphasized before.
Yeah, and the latest Nutrition Action has an article about that, about antibiotic use in our food supply.
Mm-hmm.
I don't know if you saw that. And I think they were saying Denmark had this study, you know, they wanted to see if we stopped using antibiotics in our food supply, would all of a sudden we have less animals, more sick animals, and they didn't find any difference in productivity. So it's kind of like, why are we wasting the majority of what we make for life-saving drugs, which is what it should be used for growth. So it'll be interesting to see where that goes, because people are becoming aware of it, and they're trying to buy antibiotic-free milk and meat and stuff like that. So
Yeah, because that's certainly another source of
yeah,
antibiotic exposure.
yeah, it is, and not to mention how it changes the microbes you will potentially be getting from your food supply.
Well, this is a great discussion. Does anyone have any more questions?
No, it was excellent. Thanks for coming.
Thank you for having me.
Yes.
So we don't have any cases, right? So we're done for the day.
No cases, but
Okay,
we do
and-
have PNT in 2 weeks.
PNT in 2
8:30.
weeks.
Kirsten Bennett will be presenting standard terminology in nutrition diagnosis.
Okay. And then ComTC at lunch, Kevin is doing a presentation about technology
Technology intervention in obesity.
obesity. That sounds interesting. So join us for lunch if you can.
And there was something on pertussis as well.
Yeah,
Yes.
update on
Update.
It's
pertussis.
going to be an update on pertussis from a gentleman from the Department of Health.
Yeah.
Will be joining us from Santa Fe and giving a talk. That'll be the second part of the presentation today. It all starts at noon.
Bye, everyone.
Bye.
Bye.
Bye. Thank you.